So my name's Phil Walsh. I'm Senior Clinical Educator for Mental Health at the QE in Birmingham. As Professor Tadros was saying, it's a very large acute hospital in the region of 1,500 beds. And we're going to, in the midst of all of the exciting work that's been demonstrated this morning, talk to you about a low-tech solution that we came up with in response to something that we identified through observations in care. Now, we're very grateful to the Bradford Dementia Group for their work on the PI development. Some of you might be familiar with PI as an observational tool. PI is where essentially you are trained to use this tool, but you sit and observe spheres of care for 2 hours. And Sue and I did this throughout the day and at night as well. And essentially you assimilate information about what's happening with the person, what's happening with the interactions with that person, and what's happening in the environment. And we did this over a period of months. And we were observing general care, but we also started to observe specialing practices. Now, some of you won't be familiar with that term. The way we're going to use and employ that today is to say that specialing is essentially when a nurse, a registered nurse, is concerned about somebody and they want to try and respond to that risk. Usually that presents by assigning a dedicated member of staff to be with that person. We're now talking about this as enhanced observation because of some national work that's going on. But when we started our work, and the reason we're calling it Make Specialing Special, is because that's how it was known by all of our staff, so they would know it as specialing. And what we observed was this. I'm going to have to just sit down for a moment. But we observed a number of occasions when the patient, usually older patients, frail patients, often with dementia, delirium, as we've been talking about this morning, would be assigned to have a carer with them full time. And the patient would be in a single-bedded bay area, and the special would usually, from our observations initially, be sitting. Does this look familiar to anybody? Okay, so sitting outside the door usually, but it's okay because I've got my magazine, so I'm not going to get bored. And I've got my mobile phone. So should I run out of anything to read in here, I've got a backup of getting onto my Candy Crush, and my shift will go very quickly. Okay? So, yeah. So automatically, I hope that you see exactly what we see. There's a problem with this, isn't there? And there's a problem both in terms of person-centred care, if we're talking about a moral obligation to make sure this happens, and what we were seeing. So we thought, actually, we want to change this situation. We want to change the physical dynamic about what's happening here. So as some of our speakers said this morning, we thought, fantastic, what we'll do is we'll just go down to some trust somewhere who's doing it really well, and we will just go and share their ideas, come back and employ them at the QE. So we looked, we spoke with colleagues, and we realised, similar to your response, that this is a common issue happening in acute wards today around the country. We'd all like to say it doesn't happen in our trust. I would love to say that this never happens in the QE, but I can tell you that it will happen today in some wards in some areas. So we thought this was an unacceptable position to just carry on regardless, really. Some psychologists in the room will be familiar with terms like assimilation and accommodation, which is this idea that actually our brains can only cope with so much, so you screen it out. So we knew from our observations that it wasn't that our staff were maliciously doing this. There were reasons, there were dynamics that were making this happen. A lot of it was the sheer pressure and the busyness of the environment, where staff are going rush, rush, rush to task, and then you're put into a position like being a special, and you think, right, what am I going to do? And we found some problems with this. So we'll just show you some of the problems we came across from our study. Okay. So we found when we spoke to our senior nurses and those people actually carrying out this very important duty is that there was a lack of adequate handover. Some of you may be familiar, and no disrespect if anyone's ever done this, but in the advanced practice of the hand signal handover, which is if you go down to bed 23, and I'll be with you in half an hour, okay? Obviously, it's very advanced because the person gets from that everything they need to know about the person they're going to care for. Obviously, very tongue-in-cheek. So there's a problem with that. In that, often our staff were being assigned to that and having no clue about what they were going into, what the needs of the person was, and any risks that that person may pose to them. So we thought that's an immediate problem we need to address. Delegation to staff with limited skills and experience. So we were coming across staff who were delegated into the role, who just turned up really in healthcare, and one of their first duties might have been to special. So we started to see through all of these things about too many conflicting duties for staff, so where we get them looking after a group of patients, and other factors around staff left in the observation areas for long periods of time, and you're talking whole shifts. That actually, if we're talking about asking our staff to do enhanced observation, what we're asking them to do is to raise their level of concentration to a higher level. Now, you and I concentrate on me and the other speakers for maybe 10 minutes, and then you're thinking, I want another coffee break now. So to do that for 12 hours means that there's a diminishing return on their ability to concentrate. So actually, paradoxically, we knew by doing it in the care as usual way, we were putting our patients at even greater risk than we were by having nobody there. The other thing about the registered nurses is that for some reason they hadn't really linked this to the rest of their nursing practices. So things like reviews and that were kind of very random in a way. So we thought we've got to do a whole system change. There was nothing to direct us from best practice around the country at the time, and the literature was non-existent in this area. So for the most complex care for some of our most vulnerable patients, we had nothing in the literature to say where people were doing it well. So we knew we had a big challenge on, so we decided to do a pragmatic development to change the situation. So we started to address this in more depth. Okay, so just going to whistle through these. You wouldn't be surprised to see a slide on compassion and using intelligent kindness as a way of approaching some of our most vulnerable people. But then when we compared it to this, we thought, well, that's nowhere near what we were seeing. Okay, see? And again, some of the key things about our nursing code of practice, for those who are nurses in the room, it's a duty and a responsibility to exercise our accountability in whoever we delegate to. And we were finding people who had no clue what they were being asked to do and the parameters for that episode of care. So the RCN came up with this thing about creating space, which is really our focus for today. Just to introduce Make Specialing Special in a nutshell, because we knew actually in the busyness of the environment, it's a bit like, when you're a kid and you make your sandcastle on the beach. And the first thing you have to do is create your moat, don't you? You create your moat because you know at some point the tide's going to come in. And you protect that space because of what you're creating. So we had a desire to actually create space by equipping our staff, making sure we had systematic procedures in place, which we hadn't even written at that point. But we had a vision to actually change this fundamentally so that every patient who was in that position of being in that chair had a different experience of care. And essentially what we wanted to do through all the education and training, and Sue's going to talk some more about that in a moment, was to effectively do this. That is what we wanted to do. And it's taken us 5 years to get to this point where we've moved that chair from there to there, to get to the point where we are today. So unexpected really about care plans that are individual and person-centred, and environments that are dementia-friendly. So making an acute hospital no excuse actually for not providing person-centred care. And I think, in all honesty, I think we were giving ourselves an update saying we're a busy acute hospital, what do you expect from us? Okay, Sue? Sit stuck. Here you go. Okay. Obviously, nice guidance. Very much follows the VIPS framework. So in every area we looked at, whether it's Kitwood, which we'll go on to now, Sue, or nice guidance, we knew we had to do something to change. So we've now developed a procedure, and I have, unfortunately, because my manager would kill me if I printed off more copies than this, We have 10 copies available, but we can send you copies and share what we've done in terms of framework for how we approach all episodes of specialing now. I came across this quote from someone called Nikki Gerard, who is going to present at our Dignity Conference next year. And she was talking about her experience of what her father went through. Her father was a doctor, so he cared for people. All of his working life had been caring for other people. And she said she went from seeing a man who had dementia, was at home and needed to come into hospital, but within a period of 5 weeks, he lost all of his ability to function. So he became incontinent, he lost his ability to walk, and they thought when they got him home as a family that they would be able to repair, essentially, what had happened to him while he'd been in our care. But she described it that he drifted away, and they weren't able to get him back to the person that they had 6 weeks, 5-6 weeks before. So Make Specialing Special really is our attempt to make sure that every single episode of specialing is done in a way that is professionally systematic, so that there's a good risk assessment, and we've developed a model just to demonstrate that to you. So we have what we call a patient support assessment, where we make sure that all the things we've talked about are done to a very high professional standard. We've also introduced something called a delegation record or a handover record, because we had incidences where staff would say, oh, well, no one told me this patient might actually lash out and hit me. So we thought, actually, we've got no physical record to say that a delegation instruction had taken place. So we've put that into our procedure to say that every episode of specialing will be the registered nurse saying to the person, here's what I'm expecting you to do, and it will be given in a written form as well, which both parties will sign. Person-centred intervention, Sue's going to talk about the resources and what we've developed to try and, in a kind of very low-key way, do something that is immediately into your hand, that you can go with your special to say, here's the person we need you to care for, and here's some things to get you going. And the evaluation as well, that we feel that 12 hours is too long. So we've directed really 2 hours, and then to rotate people in the team. So instead of specialing being seen as an individual approach, like you're the special for today, which fills most people with dread actually, and when we talk to people, it was on a spectrum of either boredom at one end, so extreme boredom, and trying to get attention to go to the loo for some people. And on the other end of the spectrum, it was fear and anxiety. Okay, sit. So we feel that in what we've developed, we're really responding to Kit Wood's model, his flower model for person-centred care, because underpinning all of this is the fact that everything about this is inclusive, it does offer comfort, it is occupational, and it also has that sense of attachment. So as with other things we've talked about today, when we've had examples of Make Specialing Special work really well, something shows up that wasn't there before. We had one lady who was admitted to our A&E department, and she was waiting for some tests to come back. She had dementia, and she was quite feisty actually. She was fighting with the staff and pushing them away and not wanting to be there, understandably. And then after a period of time, she became very distressed. And one of our staff who'd been through our training course then spoke to her and couldn't really get anywhere because she was too upset now at that point. So what she did was, some of you might know Birmingham, there's an area called King's Heath. And we found out that this lady happened to come from King's Heath in Birmingham. And she opened a book to Old Birmingham, so I'm sure on the My Life or the digital reminiscence software, we could pull this up for her. But we just put a physical book in front of her, and she was crying, and she just stopped crying. And she said, I know where that is. And there's something about that that's really powerful, that it's not rocket science, but just having the attention, the intentional kindness, if you like, to think this is something that we ought to do, really made a transformational difference for that patient, who was then laughing and joking about where she used to go dancing, and who she used to see when she was dancing and things like that, going back to her time as a teenager. And when the doctor came in, similar to what other speakers have said, she was able to give a very clear account of what had been happening to her, which would not have been possible 30 minutes before. And she then happily, in a way, went on her care journey from there. So Make Specialing Special is not rocket science, but we've tried to put in a systematic procedure and resources to make sure that this happens every time. So we're protecting the space for person-centred care to have a chance to show up. So I'm going to hand over to Sue now, who's going to pick up from there.
I'm hoping you're going to be my assistant and show the box for me. So a box is a box is a box, and anybody can actually put a box into their wards or departments. But we put this box in, and it may look like we've been a little tight. If Phil shows you what's inside the box, and we kind of have really, but we've done that for two reasons. Honestly, we have. The first reason is that we actually didn't have any funding for this when we first started. We were really lucky that the friends within our hospital, a charity, gave us £1,000 to distribute some of these out to the trust. So we knew that we only had £1,000. We've got nearly 1,500 beds at our hospital. So we wanted to put as many as we possibly could out. So that's why there's only a fair amount in the box. But we also wanted staff, if you pardon the pun, to think outside of the box. We wanted them to use the box as their starter for 10 really, just to find out a little bit more about each of their patients, particularly when there isn't an All About Me document filled out by a relative or a carer. And our All About Me document is very simple. It's a little booklet that explains exactly what the patient likes, their dislikes, what they prefer to be called, those sorts of things. But when that document's not available, this is a starter for 10, and it might just be the patient might pick something out of the box. So in each box there are 3 folders. There's a reminiscence folder, which has just got some very general pictures in, a couple of pictures about Birmingham, about Cadbury's and things like that around Birmingham, and some more generic pictures about adverts sort of 50, 60 years ago. There's also a poetry and a colouring book folder. I have to be very careful how I say this, but adult appropriate colouring, so not child-like colourings, although there are a couple of more simpler colourings in their folder for those patients that their dementia may be so far progressed. But there's, even if your patient cannot communicate with you, you can read them a poem if that's something that they really enjoy. So we thought it was important to put those in. Some puzzles, some very simple Sudoku puzzles and crossword puzzles, things like that. There's a pack of cards, again keeping it very simple. The other folder in there is called Have You Tried? And very much like Jo's presentation last time, where she's got it all electronically within the system, as is just a folder, and it's just general hints and tips for those staff that we know that may not have had the experience or the training and the knowledge of looking after our most vulnerable patients, those with dementia, those with learning disabilities, those kind of patients. So the box really is just a catalyst to inform staff that they've now got a role to play, and that role is to engage the person into therapeutic activity. Thanks, Phil, you did that absolutely fantastic, Yvonne. Yeah, I thought it might be. So we started, as Phil said, when we looked around at the staff that were sitting outside the room with their magazine and their mobile phone. We started thinking about what training we need to now put into place, and there's already a lot of training that goes into the staff at QE. As I said, we've got nearly 1,500 beds, there's 10,500 staff, and a huge number of our staff have now got our Dementia Friends training. We've done a lot of training around Barbara's story. For those of you that don't know, that's a DVD produced by Guys and St Thomas's about dementia. So now it was up to us about what we're going to do with that. So we've now got Make Specialing Special input into all our student nurse training that come to QHB, all our auxiliary nurse or nursing assistants, we've changed the name now, nursing assessment development programmes, we've got that in there. All the Band 5, Band 6 development programmes, we've got that in there for all the registered nurses. And there's also a new training programme called Managing a Clinical Shift that the registered nurses do. So we've got that training very much embedded into all of those programmes across the trust. Phil and I also facilitate a 2-day workshop called Advanced Make Specialing Special, and that concentrates very much on Thomas Kitwood's person-centred care and just simulation and role play for the delegates that come to that. And simulation is really important for us within the workshop because we want our participants to be able to learn through their through simulation and performing an action play to just get that certain outcome really. And outcomes do come from experience, not just reading and not just discussion. I think sometimes if you know, the fact that we're all standing up here with PowerPoints, but sometimes you can have death by PowerPoint, can't you, when you're teaching staff? So that simulation is really, really important for us to get that out there. And then following the 2-day workshop, the staff would go away and we'd ask them to complete a workbook. And the workbook proved quite difficult for us to do. We were chasing people around trying to get them to do it, and then lots of reflective practice went into that and case studies and things like that. But it was just so difficult, wasn't it, trying to get the staff to find the time to fill out case studies and reflective practice. So now what we've done, we've evolved that a little bit into e-learning, and the simulation environment provides the benefit for consistent, constant and intermediate feedback for us with e-learning. You know, the public expect professionals to engage in appropriate training, and patient groups are often shocked that, that both medical and nursing staff often perform skills for the very first time on patients. So we think it's very important for our staff to have the e-learning, and we've produced some very interactive virtual e-learning. Now this is very, very new, it's very, very basic. It's 2 days old, literally. We went to our IT guys yesterday and said, this is what we want, how can you do it? So what the staff will do, they will drag things that are important to the patient around either in the bed or the chair. It might be the make special and special box. It might be that you get the glasses round by the patient, the drink round by the patient, open the curtain so the patient can see the toilet, all those sorts of things. And every time that they drag on something, it will pop up why that's important for that patient while you're giving that one-to-one care. There are lots of benefits for e-learning. Technology is available to support all the training, and it's grown rapidly in recent years. People learn and absorb information in very different ways and at very different levels. So e-learning coupled with the instructor-led information training that we give, we know can bring additional dimensions to the enhanced learning process overall. And that, as I say, it's just a very, we're at the very start of the work with the IT team. Yesterday we had the first meeting. So hopefully this will make it more enjoyable for staff looking after their patients. But Phil's right, we've been doing this project, really 5 years? Crikey, where did that go? And everything that we've put into QEHB over the last 5 years, we've done a lot around enhancing healing environment. We've now got a couple of REM pods within our trust. We've put brightly coloured tables and chairs and pictures. We have some My Life units, or sorry, DRTS?
My Life was fine.
Yeah, My Life's fine, good. We've got all of that, but ultimately, we want to keep the patient at the heart of everything we do, as I'm sure you do, and make sure that person-centred care is offered to everybody. And if relatives can see this kind of image, they know that gives them reassurance that we're looking after their relatives, particularly when they're not able to come in and visit their relatives, such as Nikki Gerard did with her dad, John, which is what kickstart the campaign off for them. So that's what we're aspiring to, really, that all our patients get that. That was our old activities coordinator, who unfortunately we've just lost. He's retired rudely.
Wouldn't be happy with you calling him old.
No, he probably wouldn't be. Obviously, we've put a lot of information into Make Special Special. We've now designed a lot of documentation around it. If you want anything, we're happy to send it to you electronically. As Phil said, we'd be shocked if we printed loads of stuff off. But you can get either Phil or myself on the email, and I'm sure that email addresses will be shared throughout the day. So thank you.
Great. Yeah, we are, just before you finish that, sorry.
Nearly.
Wait for it. Just to say, if anybody is interested, we are happy to talk to people, because we are in a translational process with this, of going out to other trusts who have shown an interest in making it their model of choice. And it's not all singing, all dancing, but it is something that works, and it works in practice. So we're currently working with Milton Keynes Hospital, which is probably a similar size to the hospital here, actually, and they want to get all their staff trained, and they've got pilot wards already on the Make Special ethos. Okay, thank you. Thank you very much.
Well,